Thank you, Dr. Poonam. And I think what my talk today mentions is what do we do in India? And part of my talk actually is going to mainly concentrate there only. So, what we know till now from Professor Hillman's talk is where we are going to actually end up as affordability gets better and we end up having more and more advances on the therapy. So we'll come down to what we actually do in Indian context, and we'll see how exactly we will go forward in that. The main difference in terms of what we see in India versus what we see in Western world is in terms of main three major parts. We see more cases in US, 21,000 approximately every year. We see most cases with the median age is around 71 years, so they are relatively older. Very few are less than 55, and majority die because of direct cause of the CLL itself. In contrast, if you look at the India, the major differences are in three main components. We have a decade earlier median age of presentation, which is around 60 years. These are the data which are usually come from two main centers. The data from All India Institute of Medical Sciences. In terms of number, that is another difference. We look at the first publication that was 18 years data of 510 cases only. That is very limited
Hello,
case.
Dr. Ashish.
Yes,
Sir, sorry to interrupt. Please turn on your video, sir.
it is on.
We cannot see you, so that.
All right. Let me check. Can you see the slides otherwise?
Slides we can see, not an issue, sir. Yes, now it is okay.
Now
Now
it's okay? All right, fine.
the video got off again, sir.
All right, no, because I'm actually presenting from the iPad, so it may be presenting only one thing
No
at a
issue, sir. No
time.
issue. Go ahead. No,
Sure.
go ahead.
All right. So the difference, what I was talking about, is the age of presentation is a decade earlier. The number of cases are very few, which actually require therapy. So in terms of the number, and the third major difference is most of the cases can't afford. So that's what decides about in terms of difference in how we manage in India versus abroad. What uh, uh, we have understood till far, and I mean so far, in CLL is the value of prognostic markers. So we know the deletion 17p is going to be bad. We know that the deletion 13q is going to be one of the very good risk disease. Fortunately, this is the most common one, and deletion 17p is less common. Deletion 11 is somewhere in between. Now, if you look at the other parameter, which is IGHV mutated area, the IGHV mutated one usually do much better compared to what we see with the unmutated one. So these are the two parameters which is already known, and that was known even before the novel targeted therapies came in. Now, this is what is the standard in the NCCN guideline, what we should be doing in terms of the treatment for CLL. The preferred regimen is the targeted agents now, whichever category we go to, whether it is frail patient with comorbidities or it is a younger patient with no more comorbidities. The treatment has evolved into a targeted therapy. If we can't go for these because of contraindications or other reasons, then in that case, we will go to the standard one, which we were using for a long time. So this is what is essential difference between Western world and India. If somebody can afford everything, I think the treatment will not differ from what exactly is going on abroad. And as per this guideline, if the cost is a limitation, then we'll have to choose from a gamut of the other therapies which are available. Based on that, chemoimmunotherapy is still forming the cornerstone there. Now, same same thing goes for a relapsed refractory disease. Again, targeted therapies are on top along with PI3 kinase inhibitors. The recommended regimen always will be in terms of chemoimmunotherapy, whether it is young or the old case. Deletion 17p is altogether different. I mean, at all. I mean, in terms of the preferred regimen, we very well know that the chemoimmunotherapy is not going to be as effective. So, if somebody can go for a targeted therapy, it will be the best therapy. Otherwise, their outcome is not going to be too great, even if we try whatever other therapies we have in hand available. So Ibrutinib or BTK inhibitor, acalabrutinib, any of these are going to be one of the way forward, or venetoclax. These are the preferred therapies going to be. So we'll just cover in short what we have achieved and what we already know about the chemoimmunotherapy as well as BTK inhibitors. We'll be concentrating mainly on ibrutinib because acalabrutinib data we have already seen. And what we know, acalabrutinib is going to be performing much better compared to ibrutinib when we look at the data. So this is a symptomatic CLL patient of 74-year-old with bulky lymph nodes and neck, axilla, and groin. Blood counts are reasonably stable with WBC of 88,000, predominantly lymphocytosis, confirmed diagnosis of CLL, first time diagnosed, widespread adenopathy, so is reported late with bulky lymphadenopathy elsewhere. And there is a deletion 11q on the FISH testing with the unmutated IGHV isolated. So this is the background on which we need to treat this case. Now we'll have to start right from beginning, from where BTK inhibitor came in the picture. So in general, we are going to use Chlorambucil because it is a elderly person who cannot go for a chemoimmunotherapy, the other chemoimmunotherapy. So if we look at the trial, first was Resonate 2, where actually Ibrutinib came in picture. We see the difference in terms of Ibrutinib versus Chlorambucil. Ibrutinib performed much superior with a 5-year survival going up to 70% compared to with the 5-year survival compared to Chlorambucil, which we see very much lower down the ladder. Now that specifically says that actually this is why we need to switch over to the targeted regimen there. However, most of these cases were allowed to switch over to Ibrutinib at the time of progression. So that's why the overall survival was not looking that different comparatively in between the two arms. What we know already, the major side effects related to Ibrutinib, hemorrhages, fibrillation, and hypertension. What is important, it doesn't come down over a period of time. It remains more or less same with the same frequency that is coming every year. So some of these are quite difficult to manage, and that's where we need more targeted BTK inhibitor that is to be available. The similar trial, we needed a better immunotherapy, which is also available. So Obinutuzumab with Ibrutinib was added compared to Chlorambucil, which is already easily available in our country. When we look at the combination, again, this was a similar population. Ibrutinib, Obinutuzumab worked much better in terms of progression-free survival in ILLUMINATE trial. At the same time, the same mechanism was there in this trial also. There was a crossover allowed on the disease progression. Overall survival did not differ. Now, these trials did not give a detailed analysis for the mutated versus unmutated one in the initial phase. This is an alliance study, so we are looking at, we can still use bendamustine rituximab in some of the older cases who are relatively fitter. Why not try that? So this was an interesting study comparing 3 arms, Ibrutinib, rituximab, or bendamustine with rituximab, mainly to check which one works better and are they similar to each other. The patients with bendamustine arm were allowed to cross over to Ibrutinib within 1 year of progression of the disease. So if we look at the results, progression-free survival of both Ibrutinib and rituximab arm were similar, and they were superior to bendamustine arm in terms of the PFS. However, there was no difference in between the two arms. Ibrutinib, rituximab performed exactly same. In terms of side effects, it was on the expected lines. You see more hematological toxicity with bendamustine compared to more risk of hypertension with Ibrutinib. Fibrillation, surprisingly, was not a major concern in between the two arms here. What about venetoclax? So much discussion we have has taken place about this upcoming BCL2 inhibitor, where it is a finite therapy that is possible. And this was a CLL14 study design looking at venetoclax with obinutuzumab. And Comparison with the Chlorambucil with Obinutuzumab, which is otherwise available in the elderly population. Total number of cycles were given for 28 days cycles were given, and total number of duration of the therapy was 1 year. Now, what we look at here is venetoclax combination with Obinutuzumab outperformed the Chlorambucil Obinutuzumab arm by significant margin at 3 years. If we dissect it further, now we know where exactly we can fit in our population. The one with the IGHV mutation here, even with the Chlorambucil Obinutuzumab, have done equally well compared to what will be if it is an unmutated one. So in a mutated CLL40, in a mutated elderly patient with newly diagnosed, we have a choice whether they want to go for Chlorambucil Obinutuzumab or with the Ibrutinib Obinutuzumab, depending on which one they want to opt for. In contrast, when we look at the genetic profile of that, the TP53 is going to behave very badly in case we are not using venetoclax up front, and they are the one who got benefited maximum. What additional advantage was the MRD was undetectable in these scenarios. And most of these, what we know from the data available till now, are going to be long-term responders. And it is possible to give a finite duration of therapy in these cases. Adverse events were almost similar between the two groups in terms of hematological conditions. There was no major difference in between the grade 5 adverse event either and between the two groups. So to sum up for the elderly frail population, the newer oral novel therapies like BTK inhibitor and BCL2 inhibitors, they have shown prolonged progression-free survival compared to standard chemoimmunotherapy regimen. The standard guideline now include BTK inhibitor or a BCL2 inhibitor as one of the preferred line of therapy along in combination with the anti-CD20 monoclonal antibody. But in our country, we still have a role of chemoimmunotherapy in those people who cannot go for the more expensive option, particularly in the IGHV mutated CLL. What about younger fit patients? This is an example, 55-year-old with the lower abdominal quadrant discomfort that was coming because mainly of significant splenomegaly. White cell count showed absolute lymphocytosis, total count of 170,000. Platelets were low. Flow cytometry showed typical CLL. Fish revealed deletion 13q. IGHV is mutated. So this patient has all the good risk features that can be there, but he is symptomatic and needs treatment. We start from the basics of CLL8 trial, which actually compared first time between FCR and FC-arm, which made FCR as a standard line of therapy in these cases. If we look at the long-term follow-up, IGHV mutated FCR did much better compared to FC, and IGHV mutated FCR also did, unmutated FCR also did much better compared to IGHV unmutated FC-arm alone. So FCR by itself became the standard therapy for first line in a young person before the targeted therapy came in. So this became a benchmark on which we have to compare the two. However, we need to keep in mind that this trial showed a difference on a select circumstances based on tolerances. Now, this was a CLL10 trial, mainly because bendamustine came in. We saw the responses coming with bendamustine as well. So we wanted to check, yes, is it as bendamustine equally good as FCR? So this trial compared head-to-head phase 3 trial, FCR versus bendamustine rituximab in young patients. These are the results for progression-free survival and overall survival. Progression-free survival was superior in terms of FCR. Overall survival did not differ. They were salvageable later on. This trial, again, we have to read the fine lines there. The difference in survival was mainly obvious in those cases who were able to finish the entire lines of therapy, not who had to interrupt it halfway through because of the toxicity. There was more MRD negativity, more adverse events comparatively in FCR arm as per expectation. But for any patients who is tolerating the more intense chemoimmunotherapy, FCR was still a preferred choice. Now the Ibrutinib came in, so we have to compare it head-to-head with FCR. So BTK inhibitor with Ibrutinib in younger patients. This was a trial with Ibrutinib Rituximab followed by Ibrutinib as a maintenance versus Fludarabine E1912 trial. What we have got as an update is progression-free survival was much better compared to Ibrutinib Rituximab. And what we know here, unmutated IGHV, CLL have done much better with this combination of BTK inhibitor compared to what we see with FCR. On the other hand, if we look at the IGHV mutated, they did actually equally well. So FCR still remains a choice. Chemoimmunotherapy remains a choice for IGHV mutated CLL in that scenario and has a potential to provide very long-lasting remission there. Overall survival had a trend toward a better survival in that scenario. If you look at the toxicity, expected lines, more hematological toxicity with FCR compared to what we will see, and more atrial fibrillation and bleeding in Ibrutinib arm. To sum up, for a young fit person, chemoimmunotherapy shows a promising data. Novel therapies, they show a better result. They are easy to use in terms of oral therapies, but at the same time, they have their own limitations in terms of cost and the preference of the patient, depending on whether they want to opt for it or not. The standard guidelines are now to use targeted therapies. As I said, CIT or chemoimmunotherapy still has some role to play in our setting. Coming to high risk, what do we do for this case? 74-year-old patient, weight loss, fever, night sweats, all the symptoms requiring a therapy in this case. 63-year-old, already treated with FCR. We have seen a long-lasting remission lasting for 9 years. He's a relapse case after that. So FCR already did the job of providing a long-lasting remission. Now the relapse is confirmed it to be a CLL. He is positive for deletion 17p and IGHV is unmutated. So he was one of the lucky ones who got a good duration of response, but now has acquired deletion 17p mutation. There was splenomegaly, but no significant lymph nodes. Now, let's look at recapitulate the CLL8 data again. IGHV unmutated, even as the first line, and patients did not do very well. So he is in one of those categories where it actually did well and was fortunate enough. Now, when we look at the total number of 17p deletion cases in the same trial, there were very few out of the total enrolled cases of around 800. Approximately 600 were analyzed for the karyotype abnormalities, and 17p deletion was only in 51 of all, and not even a single one entered into a complete remission. So this immediately showed that the chemoimmunotherapy is not the way to go forward in these scenarios. This is a karyotypic data in German CLL study group trial also. Again, if we look at the bendamustine rituximab data on 17p deletion, the curve falls much earlier compared to the one which are showing the better risk profile there. Those with the 11q deletion are in between all the other outcomes. So the 13q is going to be much better compared to 11q versus 17p. So we have already seen unmutated is going to do worse compared to mutated with chemoimmunotherapy. So these are superior. Again, if we look the same alliance trial with the progression-free survival, deletion 17p, 11q, or neither of the two did not change the outcome for Ibrutinib at all compared to bendamustine. The curves were entirely different in the first graph when it is 17p, 11q, and even without it, outcome was almost similar in the Ibrutinib arm. So Ibrutinib Rituximab as a first line does give an option for a long-term control, and it becomes the preferable choice in those with a poor risk genetic profile. Same analysis as per mutated versus unmutated IGHV. What we know there is that Ibrutinib provides a better progression-free survival compared to uh, the chemoimmunotherapy, but the mutated one still do quite well. So there it is still a choice. All right, so then we will look at the Obinutuzumab venetoclax data, because we have already seen venetoclax can be one of the first line. Should we try that? So this is one of the initial the CLL14 trial. Again, we have seen that Obinutuzumab venetoclax trying compared with Chlorambucil Obinutuzumab. If we look at the mutation, we have already seen the overlap here in an IGHV mutated one. If we look at the cytogenetic profile, those with the TP53 right there at the bottom compared to those without the mutation. So in those without the mutation of TP53, Chlorambucil Obinutuzumab, even though it does worse in the terms of progression-free survival, it is still one of the choices for those who cannot go for a Ibrutinib-based long-term therapy. Now let's come to the relapsed refractory setting. Resonate was the first trial that was actually gave Ibrutinib the name. It was Ibrutinib versus Ofatumumab. We need to remember this was a relapsed refractory setting where most of the other drugs were used. So Ofatumumab was used as a comparative arm. If we look at the outcome, there was no major difference in terms of which karyotypic abnormality was there, whether it was deletion 17p, 11q, or no cytogenetic abnormality at all. All of them were having similar progression-free survival. So basically, BTK inhibitors are nulling the effect of the karyotypic abnormalities as a first-line response. But it is not true over a period of time. They may still lose a response over a period of time in 17p deletion. So we do need to look at if there is any progression of the disease while on therapy. This is again follow-up data in terms of progression-free survival, whether it is complex karyotype or no complex karyotype between the two groups in the Ibrutinib, and in terms of IGHV mutated versus unmutated. Let's come to the venetoclax again, which was tried first in Murano trial in terms of relapsed refractory setting. Again, to look at can we have a better response compared to bendamustine rituximab in this scenario? And what we found was the bendamustine rituximab, the venetoclax rituximab arm does much better compared to bendamustine rituximab, whenever there is a 17p deletion or without 17p deletion. And bendamustine, the progression-free survival with bendamustine was much lower. To sum up, for a high-risk CLL, deletion 17p or TP53 is a bad news in case we cannot go for a targeted therapy. The unfavorable prognostic indicators like deletion 11q, IGHV unmutated, complex karyotype, chemoimmunotherapy is not going to be an answer for most of these cases. So we should be trying for a targeted therapy in most of these cases if they are feasible in terms of the cost. The deletion 17p has already got a standard therapy as novel therapies there. In terms of relapsed refractory setting, we have not discussed too much about PA3 kinase inhibitor, but we'll leave it for the panel discussion if anybody would like to discuss it at that point of time. I'll close the discussion here. We can take up some questions, or we can take up along with the panel discussion as per the chairperson. I'll hand it over to Dr. Poonam. Thank you.